This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
So I'm going to talk about the various leukemias and really try to give you a sense that things really are changing. And we really are seeing some light at the end of the tunnel, really making some progress with these particular diseases. So leukemia, well, what is leukemia? Leukemia is really a number of different disorders, and they're all characterized by the accumulation of these cancer cells, these malignant white blood cells in the bone marrow and the blood. It's really a cancer of that particular organ, the bone marrow. Usually come to attention because of symptoms related to problems with the bone marrow. Patients become anemic, or they have bleeding because their platelet count is low, or they develop infections because they don't have the normal white blood cells. So it really gets to the normal bone marrow function that's compromised in some of these diseases at least. Types of leukemia, at least the major leukemias, we can talk about acute leukemias, chronic leukemias, two different flavors, if you will, acute myeloid leukemia and acute lymphoid leukemia. The myeloid cells, mostly cells having to do with fighting off typical infections. Lymphoid cells often have more to do with the immune system. And then their counterparts, the chronic myeloid leukemia and a chronic lymphocytic leukemia. And they're all very different diseases. To give you an idea of how common or perhaps how uncommon these might be, here's some statistics, recent statistics from the US. Overall, there's about 15 new cases per 100,000 individuals in the United States. And it's broken down shown here, where CLL is the most common of the leukemias in adults. Now, to put that in perspective, because sometimes these numbers don't mean a whole lot in abstract, here's the estimated number of US cancer cases for 2006. On the left, you can see for men about 720,000 new cancer cases, mostly prostate cancer. You can see that leukemia is about 3%. It's near the bottom there. And you don't even see it show up on the side of females, where there's almost an equal number of total cancer cases. So in the big picture of cancer, they're not common, but of course they're important to anyone who has one of these disorders or to families where a family member might be affected. When you look at the incidence rates over the past quarter century or so, you can see, again, prostate cancer is the most common in men, and that's actually declined. Lung cancer, colon cancer. The leukemias really come near the bottom of this slide. There isn't even a line for them. It's really near where the non-Hodgkin's lymphomas are, for example. And for women, it's similar. Of course, the most common cancer in women is breast cancer. And again, the leukemias would be near the bottom of this graph. But they are quite important. They really have a big impact on people's quality of life. In terms of survival, when you look over decade to decade, going back in the 70s, you can see we have made some progress with some cancers. With leukemia in particular, there has been progress in terms of overall survival from about 33%, about 1 in 3 individuals, now to almost half of individuals. So clearly there's been progress made over the last several decades, and I'll show you some of the reasons for that. So let's start with acute myeloid leukemia. This is largely a leukemia of adults. When you talk about leukemia in kids, you're really talking about, for the most part, acute lymphoblastic leukemia. That turns out to be the most common cancer in children, unlike in adults where you see all these other solid tumors. But acute myeloid leukemia, the most common of the acute leukemias in adults. There's about 10,000 new cases per year in the U.S., and it's a disease of older individuals. The average age is over 60. It tends to be highly aggressive. It has a complex clinical course, and there's major risk factors in terms of how well people do. Unfortunately, one of those risk factors is age, and of course, it's more common in older individuals. And the other has to do with abnormalities in certain chromosomes, and I'll highlight a few of those. Now, if you don't treat this, average survival is measured in weeks or months. Individuals often die of infections, for example. And unfortunately, relapse is common. The majority of patients still relapse. And when you look at overall survival out a number of years, it's not all that good. It hasn't been all that good. But we are making incremental progress, and I'll highlight some of that tonight. So when you look at large series of studies over many years, this, for example, is from one of the cooperative oncology groups in this country, looking at individuals less than 55 or over the age of 55 in the bottom curve here, 1,000 patients less than the age of 55. The survival out to 5 years, for example, is a little over 20%. If you look at older individuals, the survival is closer to 10%. And until recently, we really hadn't made much progress in changing that outcome. When we look at therapy for this type of acute leukemia, we use certain terminologies. Of course, patients are diagnosed. We start their initial treatment. We call that induction. That's usually a prolonged hospitalization, and we hope to achieve remission. But that doesn't mean that we've gotten rid of the leukemia, because if we don't do anything else, it almost inevitably comes back, and so we go on to give additional courses of chemotherapy. We call that consolidation in some cases. And then, unfortunately, many individuals relapse. Can we use some other kind of chemotherapy, salvage chemotherapy? How about newer approaches? Instead of standard agents, let's use some antibodies, immunochemotherapy. I'll show you an example of that. And then how about transplant? Hematopoietic stem cell transplant. Fortunately, we're able to explore this increasingly in older individuals because of new ways of doing these transplants, so-called mini transplants. So you'll see more about that in the literature and in the popular press as well. So how should we approach treatment for acute leukemia, myeloid leukemia? Traditionally, it's been rather nonspecific. We use agents that are highly toxic. They often are directed towards cells that are dividing rapidly. And of course, they'll affect normal cells that divide rapidly. You lose your hair. You can damage your stomach, the lining of your GI tract. You can have other problems that are unintended, but really are reflective of how that chemotherapy drug works. And unfortunately, they're often not all that efficacious in truly eliminating the disease. So how about so-called targeted therapies? There's a lot of newer targeted therapies. What does that really mean? Well, we hope it means that they're less toxic, and we hope it means that they're more efficacious. So what's an example of a so-called targeted therapy? How about an antibody, a molecule that will target a specific receptor or a molecule, hopefully one that's present only on the cancer cell and not on normal cells. One example of that is an antibody called gemtuzumab ozogamicin. It goes by the trade name Mylotarg. This is an antibody that's linked to a very potent chemotherapy drug. It's a chemotherapy drug you could never use by itself because it is much too toxic. It would damage normal cells. But if we can target it to where it needs to go and get it into that cancer cell, maybe we can have better efficacy without all the toxicity. So this is an antibody, and it's been engineered and altered so that our body doesn't reject it. We call that humanized. We link it to this anti-tumor antibiotic. It's actually an antibiotic, but it's a chemotherapy drug. And the target is a molecule called CD33 that is found on most acute myeloid leukemia cells and not on normal cells. So schematically, here's how it works. There's our cell, and in blue you can see the nucleus, and that little spiral there is the DNA. So we have our humanized antibody. It targets and recognizes that CD33 antigen, and it's linked to that calicheamycin, that anti-cancer drug. It gets internalized into the cell. You want to get it where it's going to have its activity and not allow it to damage surrounding cells. It then migrates to the nucleus. And when it gets to the nucleus, it binds to the DNA. What it does to the DNA is it causes some bending in the DNA. It makes it unstable, and as a result, the DNA breaks. So you're really getting to the heart of the cancer cell. You're really targeting its DNA, causing that specific cancer cell to die. Now, by targeting that particular cell and internalizing the molecule, you release that anti-tumor drug within the cell, so it's not having effects on the normal blood cells or on the normal tissues. This, of course, leads to cell death. So this particular agent has been used in patients with relapse disease. It's being explored now as part of upfront therapy for patients with acute myeloid leukemia in combination with standard therapies. And it's also being studied now in a large national trial for maintenance type therapy. Patients who have gone through therapy, who are in remission. Can we add this kind of treatment and thereby decrease the risk of patients relapsing? Now, we also have new technologies to really try to understand this disease and try to determine new targets. Can we look at this disease in a different way and develop new therapies? Here's one example. This is so-called DNA on a chip analysis. This is a technology that's been pioneered in part here at Stanford. And what it does is it asks, we can put thousands of different genes on a little microchip. And we can look at various characteristics and sort those out. Ask questions like, are there certain genes that are expressed in certain tumors at certain stages of development, when patients relapse, when they're first diagnosed? Here's an example of simply taking several hundred patient samples with different types of acute myeloid leukemia, samples that are well characterized for certain aspects of leukemia, different chromosome abnormalities, for example. We know how these patients typically do. And asking the question, are there different gene patterns that independently identify these different groups? And pictorially, what you can focus on here is the red areas. Red means things are overexpressed. Green is underexpressed. So if you look, for example, about halfway down on this slide, there's a big red area. That corresponds to a number of different acute myeloid leukemia samples. And it turns out that they all have a common chromosome abnormality. So we already knew that there were differences in leukemias based on chromosome abnormalities, and simply by doing this sort of analysis up front, we can independently identify them. One could imagine that eventually we might be able to develop individual profiles of different types of acute leukemia that might respond differently to therapies. We might be able to better individualize therapy for the acute leukemias. Now, many patients don't have a chromosome abnormality. They have normal chromosomes, and yet it's a very heterogeneous group despite that. So in this particular study, they focused on those with normal chromosomes, and they actually fell into two distinct groups based on this kind of gene profiling. One is shown in red, one is shown in blue, group 1 and group 2, and you can see at the bottom left-hand corner that they tend to segregate into two different clusters. And on the bottom right-hand corner, they show these two groups in terms of survival. How did these patients actually do? simply their profiles, how they clustered, independently predicted on how well these patients did clinically with treatment. So it might give us some insight into the differences between groups of patients with acute leukemia. It might be a first step towards understanding what genes are responsible for the differences that we're seeing here and how patients respond to treatment. We have other technologies. The upper left-hand corner is standard chromosome banding that we use for all of our patients with acute leukemia. The one in the upper right is using a simpler technique where we use little probes that have different colors, looking for specific abnormalities in chromosomes. We can look at a larger number of samples. It's a little easier to use. The bottom left-hand corner is what's called spectral karyotyping. It's basically painting each different chromosome in a different color. So if you see pieces of chromosome swapping, you can detect that by seeing two different colors being put together. A little easier way of detecting subtle differences in samples. And a fourth sample is shown on the bottom right-hand corner that's called comparative genomic hybridization. We also understand that there are specific mutations that play a role. One such mutation is called FLT3. This is found in at least a third of patients with acute myeloid leukemia, and we know that it confers a worse prognosis. It leads to an activation in one of the markers on the surfaces of the acute leukemia cells, and it really leads to an opportunity to target that. Can we target that molecule and really inhibit that activation? Will it make a difference? As a result of this type of analysis, there's several investigational drugs in clinical trials. These are oral drugs that are being used in combination with standard chemotherapy to see if we can increase the efficacy, improve response rates, decrease the risk of relapse. One such trial is ongoing here at Stanford at present. So we have a variety of different treatment approaches, and it's really based on not just intensive chemotherapy, standard chemotherapy to kill cells that are dividing, but really being smart about looking at the differences between these leukemias. In some cases, there's a mutation. In other cases, two pieces of chromosome swap, leading to a new protein that we can target. So we're starting to really subdivide this disease into smaller groups that we're better able to target with some of our therapies. There's one particular type of acute myeloid leukemia which is a real success story. This is called acute promyelocytic leukemia. We used to fear this leukemia because it had a unique complication. Patients would have a very significant increased risk of bleeding because of the nature of these leukemia cells. It's caused by two pieces of two different chromosomes, chromosome 15 and chromosome 17, swapping, translocating. As a result, at the break point on one of the chromosomes, the promyelocytic leukemia gene gets put next to a gene at the break point of the other chromosome, what's called the retinoic acid receptor gene. So you have two genes put next to each other, and as a result, they're activated. They produce a new protein. That, in turn, leads to the leukemia. So the idea would be to target that protein. Well, the recognition that one of the genes involved was called retinoic acid responsive element led to investigators, initially the Chinese, saying, well, let's use all trans retinoic acid. You've heard of vitamin A? That's a retinoid. This is a different form of retinoid. This is a drug that had been in use in traditional Chinese medicine for centuries. And it was used in China, and they noticed that it really worked in this particular type of leukemia. So they published their results. Everyone in the Western world was surprised by how efficacious it was, but then when it was repeated and confirmed, it really caused a revolution in the treatment of this leukemia. So for example, this was a study done in the US among the cooperative oncology groups where they asked the question, does atra make a difference? Let's add it to standard chemotherapy at the time of induction, or at the time of induction plus later, or let's leave it out entirely. So here's how patients did. The bottom curve, patients doing the worst. Here you've got a disease-free survival of about 20%, like most acute myeloid leukemia. Those patients got standard treatment. They did not get any atra. And the top curve, the patients who did the best, are patients who got standard chemotherapy and also got atra during their initial treatment and later during their subsequent treatment. So we changed a type of acute myeloid leukemia from a survival rate of less than 20% to a survival rate today of close to 80%. So an astounding difference from this one drug, which, by the way, is a pill. Causes dry skin, like vitamin A does. So a real success story for at least one subgroup of patients with acute leukemia. We are also using arsenic now, again, based on an observation from the Chinese. We know that arsenicals have been used in traditional folk remedies over the years. One of the giants in medicine, Paul Ehrlich, used this. It's been used to treat syphilis. A drug called Fowler's solution that contained arsenic was used in the last century to treat another leukemia, chronic myeloid leukemia. So there's a long history. Well, again, this was brought forward in a less toxic form. We give it intravenously. For patients who relapse with this disease, we can put 80% into remission. And it's now being used in combination with our standard chemotherapy drugs, with atra for the initial treatment of this disease. So it's kind of humorous to have our patients in the clinic and to be talking to them while we're giving them arsenic. It really is something that I don't think anyone would have anticipated. So atra and arsenic trioxide, along with standard chemotherapy, now can cure the majority of patients with this particular disease. And we're now asking the question for some of these patients of, can we use less therapy? Imagine that. We're at a point where we're doing so well in some of these patients that we're trying to limit the toxicity, limit the exposure to these drugs. So in fact, the next national trial for some of these patients with APL will ask that question. It's a trial that will be centered here at Stanford, but basically everyone in the country with this disease who has a low or intermediate risk will have the opportunity to be treated on this particular protocol. Let's switch gears a little bit and talk about one of the chronic leukemias, chronic myeloid leukemia. Now this is a real success story. This is the poster child for targeted therapy for cancer. Not just leukemia, but for cancer. This is a disease that affects, on average, a younger patient population. Median age is 45 to 55 years, although the incidence does increase with age. And 12 to 30% of patients are over the age of 60. Interestingly, about half the patients are diagnosed because a laboratory test was done. You have an insurance physical, you see your internist, and there's an abnormality. The white blood cell count is high. Not necessarily because you have symptoms. So in fact, more and more patients don't have symptoms when they're first diagnosed. And the majority of patients, fortunately, are diagnosed during the very earliest phase, what we call the chronic phase. So as I mentioned, fully half of patients are asymptomatic at the time of their diagnosis. They might have fatigue if they're anemic. They might have some weight loss or loss of appetite. They could have some abdominal fullness because many of these patients have an enlarged spleen. So that's what you might notice on a physical exam. We give certain names to different stages of this disease, the chronic phase. Inevitably, the natural history of this disease without therapy is an evolution to acute leukemia. And we give it a special name with this disease. We call it a blast crisis. If you think treating acute leukemia is difficult when it arises by itself, if it arises from a disease like this, we really can't cure it with standard chemotherapy. We have an intermediate phase called accelerated phase, which is really just sort of a transition. But most patients, fortunately, are diagnosed in chronic phase. Now, this leukemia is due to a very specific translocation, swapping of two pieces of chromosome, like I mentioned with acute promyelocytic leukemia. Chromosomes 9 and 22 swap two genes, BCR and ABL, forming BCR-ABL. This new gene leads to a new protein. That protein is something called a tyrosine kinase. There are a lot of tyrosine kinases that we have, and there are now a lot of different tyrosine kinase inhibitors in use for cancer chemotherapy, for some solid tumors, but this was the first, CML. So it was logical. Let's target this tyrosine kinase. Let's shut it down. If we're able to do that, then shouldn't we be able to shut down the disease? And the answer is yes. Traditionally, we could use stem cell transplant, allogeneic stem cell transplant, get stem cells from a matched brother or sister. Unfortunately, really only available to patients up to the age of 50 or so until recent years, where we're using different approaches, and most patients are over the age of 50. We used interferon, a drug that had a lot of side effects, a drug you have to give yourself by an injection, like an insulin injection. We use some standard chemotherapy drugs, hydroxyurea, a pill that you take. It's great, it controls the blood counts, but it doesn't change the course of the disease. And then came along this drug, imatinib, mesylate, or Gleevec. This drug made the cover of People magazine, to put it in perspective. It really was a revolution in cancer therapy. And here's how it works. There's our BCR-ABL. What it needs to do is it needs to bind to its target. We'll call that the substrate. And it's an energy-dependent process. That energy is supplied by the molecule called ATP. It really has to transfer one of its phosphate groups, shown in yellow, a yellow ball, onto a particular residue called a tyrosine residue, one of the amino acids. That, in turn, that phosphorylated target will then bind to the effector cell, the cell that it's going to have an impact on. That sets off a whole chain of events leading to the malignant transformation. So let's target that. Let's find a molecule that will bind that site where this energy molecule needs to bind, and thereby prevent the activation of that substrate, thereby prevent binding to that effector cell, and thereby shut down that signaling process that leads to the malignancy. It seems simple. It is a simple concept, and it really works. So to put this in perspective, what we want to achieve is we want to suppress that Philadelphia chromosome. We want to make it go away. With hydroxyurea, it happens in 0% of individuals. With interferon, maybe 20%. But with imatinib, with Gleevec, you can get 80% of patients achieving complete disappearance of the Philadelphia chromosome. That translates to long-term survival. This drug is very well tolerated. There have been patients on this drug for 5, 6, 7 years. It's a pill that you take once a day. I really kind of compare it to aspirin as far as its side effect profile. So imagine going from a situation where you're talking about a transplant with at least a 20% upfront risk of dying of complications of the transplant, potentially curative, to taking this pill once a day and fundamentally altering the course of the disease. So a very exciting bit of progress for treating this disease. It's completely revolutionized the treatment of chronic myeloid leukemia. Well, we knew that this drug targeted the BCR-ABL, but we also knew from the laboratory that it targeted some other molecules, something called KIT, c-KIT, for example. People said, well, you know, this molecule is highly expressed on this unusual type of solid tumor, gastrointestinal stromal tumor. So they started using it there. And here's an example of what we call a PET scan. That's a human torso there on the left. All that black in the abdomen at the bottom, that's tumor, solid tumor. And in the middle panel there is a cross-section, a CAT scan. Panel B is shortly after taking this drug Gleevec. And panel C is a little bit later. Dramatic results. This is an invariably fatal tumor. When the investigators were first using it, they really likened it to seeing Lazarus rising from the dead. That's how dramatic it was. So an example of knowing how something works and applying it to a completely different situation because of its mechanism. And another example, again, because of a recognition of what Gleevec targets, this is a very unusual disease that leads to the kind of disfigurement you can see in this woman's face on the right. Unresponsive to all prior therapies. She'd had this for many years, and you can see after a course of Gleevec the dramatic difference, the dramatic improvement in the quality of this woman's life. So a disease that's found a therapy that's found more than one use. Now, if that weren't enough, we actually have new drugs, new oral drugs that are tyrosine kinase inhibitors that work even in patients who no longer are responsive to Gleevec. These are currently in clinical trials. We're doing clinical trials with both of these drugs here at Stanford. We were involved in the initial clinical trials with Gleevec, and this is very, very exciting. We're seeing patients respond who had never had a chromosome response to Gleevec, patients who have developed mutations so that Gleevec no longer binds to that BCR-ABL protein. So you'll see more about this at the next National Oncology meeting. I'm sure it'll make the newspapers. I think there's real potential, actually, for one of these drugs to replace Gleevec for the treatment of chronic myeloid leukemia. What about our most common leukemia in adults, chronic lymphocytic leukemia? Well, traditionally, in medical school, throughout your training, oncologists were taught that this is really a disease we can't cure. It's not fatal. Patients survive for long periods of time. They die for other reasons than CLL, and we really can't impact survival with our treatment. Therefore, we should try to palliate patients. We should treat with agents that cause the fewest side effects rather than necessarily treating with those agents which are most effective initially. We would talk about complete responses, but we conveniently ignored that a complete response didn't mean you couldn't detect disease. Now imagine treating a woman with breast cancer who wants to know, is it gone? Is the disease gone? Am I potentially cured of breast cancer? We sort of ignored that with CLL, partly because we really didn't have good drugs to achieve those kinds of responses. But that's changing. We have new prognostic factors now that tell us who's more likely to progress sooner, who's more likely to need treatment sooner, who should we target our therapies to earlier. This is a disease which is often indolent, not aggressive initially. In fact, for many of our patients, most of our patients, they're asymptomatic when they're diagnosed. And we counsel observation. We don't jump in and treat right away. And that's because treating right away, at least with our traditional therapies, didn't make a difference. It did make patients live longer. And so we took the watch and wait approach until patients progressed, and then we started therapy. But if you're in that group of individuals, you've just been diagnosed, even if you don't have symptoms, you want to know how you're going to do. How am I going to do? When am I going to need treatment? What's my prognosis? So we have some new prognostic factors I'll show you that can help give people more information about that. We have new therapies, again, these antibody-based therapies, and we have new goals of treatment, more sensitive ways of monitoring our treatment outcomes. So prognostic factors. One of these is chromosomes, chromosome abnormalities, not the kinds of swaps that we see in the acute leukemia, but in this case, often just deletions of parts of chromosomes. So this is from a study looking at patient samples that had been banked over the years. They knew how these patients had done clinically, and they asked, do certain chromosome abnormalities predict the eventual outcome of patients? And the answer is yes. So for example, in the green line on the left, those who had this particular abnormality involving chromosome 17, on average, these patients needed treatment in less than a year. Now that's surprising. If you see an average patient with CLL walk in the office, recently diagnosed, if you see them come back in less than a year and need treatment, for the average patient that's unusual. Well, this would predict that. The other end of the spectrum in yellow is those who have an abnormality involving chromosome 13. And you could see there, on average, those patients didn't need treatment for about 8 years, 8 or 9 years. A huge difference in an otherwise similar group of individuals. But what do we do with this information? Does it mean we should treat some of these patients sooner? So we have a spectrum here. We have a hierarchy, if you will, going from that chromosome 17 abnormality, where we know a particular tumor suppressor gene is located, all the way out to chromosome 13 abnormality. Those with normal chromosomes fall somewhere in between. The nice thing is we can use one of those techniques I showed you earlier, this FISH technique, where we use colored probes to look for these abnormalities in the blood. We're not dependent on obtaining a bone marrow sample from patients to get this information. We have another marker, prognostic marker. This has to do with mutations in a particular gene, what's called the immunoglobulin gene. And simply put, you can look at patients who have excess mutations in those genes, in those CLL cells, versus those who don't yet have those mutations, and it makes a difference. So in blue are shown those who are mutated. Those patients do better. So in this case, mutated is good. But again, a very simple distinction that really takes a group of individuals that otherwise have the same outcome and really divides them. Some need treatment sooner, much sooner. Some live longer. How do we use this information in making treatment decisions? Finally, we have a marker called ZAP70. It tends to correlate with the mutational status, but hopefully, as we work out the kinks in this particular test, we'll be able to use this routinely at the time of diagnosis. This is a gene that was determined from that genes on a chip type of analysis that I showed you earlier, that seemed to be associated with the unmutated status. So unmutated is bad. Most of those patients had overexpression of this particular protein. This is also a tyrosine kinase, by the way. And you could see here on the left the risk of disease progression, the risk of needing treatment. If you had ZAP70 expression in green, on average, you needed treatment within about 3 years. Whereas if you didn't express ZAP70, the average time to needing treatment had not yet been reached in this study. And the same is true in terms of survival, how these patients did. You take this information, you say we have better ways of predicting who might benefit from earlier treatment because they have a higher risk profile, and you add to that the fact that we have better agents for treating this disease, and I'll show you a few of those. So the time has come to really re-look at this whole issue of watch and wait. Better prognostic factors, better agents. So the hypothesis is that if you can intervene early with effective therapy in patients who are high risk, even if they don't have symptoms, and we're going to define high risk as this unmutated profile, then we can improve survival by fundamentally altering the disease. We can prevent some of the secondary events that occur over the lifespan of these CLL cells. And so as a result, there's going to be a new a US trial starting up where patients who are newly diagnosed will be screened for this particular mutation. If they are mutated, traditional observation. If they're unmutated, they're going to be randomized. Standard observation versus early intervention with two drugs called fludarabine and rituximab. Now, those prognostic tests are available here at Stanford. We developed them in the research lab. They were brought forward into the clinical lab. They're now available for physicians to order on their tests. The mutation analysis in particular is not a test that's widely available at all. We're one of the few institutions that offer this in our clinical lab. How about newer therapies, monoclonal antibodies? Now, people think that monoclonal antibodies are new or antibody therapy is new. It isn't. This is Paul Ehrlich. This is a quote from him from about a century ago. He said, "You see, we must take aim by chemical variation. The marvelous effect of an antibody in the serum is due to the fact that in no case it has an affinity for the body substances, but flies straight onward without deviation upon the parasites." He called them magic bullets. So we often think that we coined this term in the modern era, but we really didn't. And here's an example of antibody therapy. So this is a cartoon. There's your friendly corner druggist, and he's got his horse there, and he's tapping that horse like you tap a maple tree for maple syrup, and he's getting horse serum. He's getting serum that contains antibodies against diphtheria. And there's everybody lined up. There's a little child to get that anti-sera for the whooping cough, diphtheria. In fact, this was the basis of a Nobel Prize. So antibody-based therapy goes way back. It's just that we have better ways of making antibodies, these so-called monoclonal antibodies. One such antibody is called rituximab. This was the first antibody used for cancer. It's now used widely in the lymphomas. In fact, we joke that it should be added to the water supply because it's found ever increasing number of uses. In fact, it was just recently approved for treating certain severe cases of rheumatoid arthritis, not just cancer. Here's an example of combining some of our chemotherapy drugs, fludarabine, Cytoxan, and rituximab, all three together, a study done by my colleague, Dr. Michael Keating in Texas. And you can see overall response rates of 95%, complete or partial responses. To put that in perspective, if we took one of these drugs, a similar drug, chlorambucil, similar to Cytoxan, took that by mouth, you might see 3% of patients achieve a complete response. If you used fludarabine alone, you might see about 20% of patients have a complete response. So clearly, combination therapies with antibodies are making an impact in treating this disease. We have a second antibody called Campath or alemtuzumab. That's shown schematically here on the right. This is a humanized monoclonal antibody as well, and it's been used initially extensively in patients with relapse disease, patients who had really run out of other options for treating their leukemia. And in this study, what it's showing is the survival of patients in white there with traditional therapies once they'd become resistant to standard chemotherapy drugs. They lived on average for about 10 months. In the pivotal study where Campath was used as a single agent, for patients who responded, the average survival was about 2.5 years. For all patients treated, it was about 1.5 years. So a big advance. We're now using this drug in combination with some of our standard therapies as well. So conceptually, I think one way of looking at the treatment of CLL and the advances that we've made is shown here. The line in the blue is treating with chlorambucil. That first horizontal black line is complete response. We can get a few patients down to that complete response line, but inevitably that blue line comes back up. Patients have disease that needs to be treated again. Fludarabine in red, we can get more patients, 1 out of 5 or perhaps 25% of patients below that we call a complete response, but inevitably the disease becomes evident again. Patients need to be treated again. We need to shoot for a different goal. We need to treat patients to a point where we can't detect any residual disease by the best techniques available to us. That's called minimal residual disease negativity, and we now have ways of doing that. We can use techniques that are available in our clinical lab from blood samples or bone marrow samples to ask the question, can you detect any CLL cells in patients who have been treated? So can we get them below that second black line to where they're MRD negative? And the answer is yes. We've demonstrated that in combination regimens with monoclonal antibodies and fludarabine. We've demonstrated that with single agents like Campath. Some patients who have had transplants using stem cells from themselves have achieved that. Now what we need to do is ask, can we cure patients? Can we take that blue line and bring it down to the baseline where we really, truly eliminate the disease? Should we use maintenance therapies? How about new agents? How about these new types of transplant? And we're exploring all of those options. We'll have several investigational agents. Interestingly, some of these agents are being used for other leukemias. Dasatinib that I showed you for CML, I think will have activity in CLL. So we're very excited about hopefully being able to use that for this disease. My colleague, Dave Miklos, in the bone marrow transplant program, has novel ways of applying transplant techniques, hopefully less toxic, for patients with CLL. We really need a comprehensive approach to start talking about curing patients with this disease. And finally, just one slide on acute lymphoblastic leukemia. Again, the most common cancer in children, really a success story in pediatrics. What's shown here is the outcomes of patients' survival over the decades from a series of protocols in the children's cancer group. You can see the first from 1968 to 1970 at the bottom. The majority of patients died, 10% overall survival, and then over the decades, those survival curves have improved to the point that the vast majority of kids with ALL are being cured of the disease. This has come about not necessarily because of novel drugs, but in particular, in the last several decades, it's not due to new drugs. It's due to a better understanding of how to apply these drugs, a better understanding about who to treat, how to treat, when to treat, and in fact, all of the advances we have made in treating adult ALL has come from really studying the experience of our colleagues in pediatrics. So there's still a long way to go in adult ALL because we don't get these kind of results. We're still sort of stuck at about 40%, a 40% cure rate for adult ALL. So what are some of the major questions remaining in leukemia? One big question, you've heard all about stem cells. Of course, it's in the press. It's a hot item here at Stanford. We're not talking about the embryonic stem cells necessarily, but we're talking about cancer stem cells. Pioneering work done by Dr. Irv Weissman here at Stanford in his laboratory, looking at cancer stem cells. Is there a pool of stem cells in acute myeloid leukemia that's protected from our standard chemotherapy drugs? A quiescent pool, cells that aren't dividing rapidly. We need to think of different ways of detecting them, different ways of targeting them. What about in the other leukemias? How about in CLL? Is there a pool of stem cells that we need to be studying? Why does nonspecific chemotherapy work when it does? And why does it fail when it does? What are the mechanisms of resistance? How can we overcome that? We're applying some of those concepts in a clinical trial in acute myeloid leukemia currently. We think that in many patients, they become resistant to chemotherapy because of certain mechanisms within the cell. A pump that literally takes that chemotherapy drug and pushes it back out of the cell, so it's not effective. So we're using drugs to block that pump, make the chemotherapy more effective. Why does the nature of acute leukemia change with age? Why is it so difficult to treat older patients? It's almost as if it's two separate diseases. It's not just that we can't tolerate as much chemotherapy as kids. There really seems to be a fundamental difference. Should we continue to study old drugs? How should we study new drugs? So I think the state of affairs right now in terms of leukemia research can be thought of in three categories. There's the good. We have better understanding of targets and pathways. I've shown you some examples of that. We have many new drug candidates. It's really an exciting time to study some of these diseases because we feel we have things to offer patients that's really going to benefit them. We have greater availability of different markers of outcome to allow us to assess these drugs. The bad is if we start slicing up the categories too much, there's fewer patients to study and to really learn how good these agents might be. We may need combinations of drugs that individually are ineffective, and we wouldn't know that. We would try this drug, it wouldn't work. We'd try this drug, it wouldn't work that well. But if you combine the two, maybe it would work a whole lot better. We certainly have examples of that already. There's increased competition, and there's confusion about what the acceptable endpoints are when we're doing some of these clinical studies. And the real ugly is just an increasing environment of greater regulatory burdens, the paperwork, the rules, the regulations, some of which are very well-meaning, but in practice, they really can hold us back at times. Diminished support for clinical researchers. Really having the financial resources to be able to do these kinds of studies. This is not financial support that comes from the federal government. That's by and large for basic research. And the traditional issues between academics and industry, I think that's gotten a lot better. And I think actually at Stanford, we have less of that as an issue. There's always been a very entrepreneurial spirit here. There's always been a lot of interaction between our colleagues in the biotech industry. So for more information, there's a lot of resources here at Stanford. There's a health library. There's a website. We have a brand new cancer center. We're really paying attention to cancer. We're really trying to make our therapies better. We're really trying to make the experience better for patients who have to undergo these therapies. So I'll stop there, and thank you for your attention. I'll be happy to answer any questions that you have. Why is the success rate for adult ALL so low? It's a variety of reasons. I think when we look back at the success we have had, it really comes from using the sort of approaches that the pediatricians used. But despite that, we're sort of stuck at that level. Part of it is it's not a common disease in adults. It doesn't get the attention that it really should. There really haven't been any novel agents. Until very recently, there was one approved for relapse disease in children. And it really lacks still from some of the fundamental understanding of the mechanisms of disease. Is there a relationship between CLL and lymphoma? So when we talk about lymphoma, people think of, well, those are tumors of the lymph nodes, our lymph nodes here in the neck and under the arms, etc. Those are cancers of blood cells, of course. Leukemias, remember, by definition involve the bone marrow, where our cells are made. Some patients with lymphoma have involvement in the bone marrow. And if those cells then come out into the blood and circulate, we call it leukemia. So in fact, there's a disorder called small lymphocytic lymphoma, which for all the world looks exactly like CLL. The cells look the same. They have the same markers. But some patients don't have bone marrow involvement. They don't have circulating leukemic cells, and we call it SLL instead of CLL. So the question is, does leukemia in the bone marrow involve all of the bone marrow cells? Well, we have our very earliest stem cells, and those give rise to various other cells, one of which is a stem cell that leads to all of our blood cells, leads to our platelets that help with blood clotting, our white cells that include the myeloid cells, the lymphoid cells, and our red blood cells. And often these diseases, these leukemias, involve the very earliest blood stem cell. We know that's true with chronic myeloid leukemia, for example. And so that is a very important issue because it tells us that we have to target those very earliest stem cells if we're really going to eliminate the disease. That gets to that whole issue of cancer stem cells, really trying to understand what these diseases is, if there is a pool of those stem cells, because we can kill these rapidly dividing cells. We can kill the cells that we can see and that we can detect. But if we don't know about this other population of cells, if we're not looking for that, then we don't know if we've eliminated that. What triggers the onset, for example, of AML? We can ask that about any of the leukemias, for example. And unfortunately, with rare exceptions, we don't know. There are some secondary acute myeloid leukemias, people who are exposed to certain toxins, people who have had prior chemotherapy. Some of these chemotherapy drugs damage the DNA and put you at risk for developing an acute myeloid leukemia later. Some, like APL, really are just probably initiated by that translocation, putting those genes together. Now, what triggers that, we don't know. Most, though, are probably multi-step. You might have a predisposition to it, but there still needs to be something that triggers a change in that particular individual. How do we approach clinical trials in these patients? Can we just use a lot of different agents and try them and see what happens? Or do we have to use a fundamentally different approach? And I think the answer to that is both. In some cases, CML is a great example. We had a very good idea of what caused that disease, what led to the transformation of those cells. We could target that. We were able to target that, and it worked. What a great success story. That's a home run. But we're not going to have those home runs in most cases because these diseases are much more complex. They're much more heterogeneous. Now, we can take subgroups of them. We can take APL and have a great success story, but that leaves everybody else. So you're right. I think it does require a fresh look at these diseases, a better understanding. And I'm confident that with some of the technologies that we have now, we are really much better able to look at very large numbers of samples, very large numbers of individuals, and start asking those kinds of questions. The ZAP70 assay, at present, it's not available in the clinical lab, and this really reflects problems that everyone has had around the world. This uses an antibody to detect a marker on the CLL cells, the ZAP70 antigen. And it's not a very robust antibody. So when you're, as any good lab does, you have to do your quality control. Can you really determine what's truly negative versus what's truly positive? Can you be confident when you're reporting a result that it's accurate? And in many cases, the answer was no.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.